there, curious minds. Welcome to the Deep Dive, your shortcut to being truly well-informed. We take stacks of information and, well, we pull out the most important nuggets, the surprising facts, and those aha moments that really stick with you.
And today, we're embarking on quite a fascinating deep dive. It's a world that demands incredible precision and patience. The intricate relationship between orthodontics and orthognathic surgery.
Orthognathic surgery, that's jaw surgery, right?
Exactly.
Okay.
Think of it as mapping out a truly transformative journey for your smile and, your facial harmony, but with layers and layers of advanced science involved.
That's right. We've got some incredibly detailed source material here, a chapter from a leading textbook called Orthodontics for Orthognathic Surgery. It's packed with insights from experts like Larry M. Wolford, Aber L.L. Stivo, and their colleagues. I mean, this is dense stuff.
It really is. And our mission for you today is to sort of pull back the curtain on the essential role of the orthodontist, everything from the initial prep work to managing things after the jaw surgery. We'll get into the complex diagnostic tools and treatment strategies that are just absolutely crucial for achieving those optimal, stable, functional, and of course, aesthetic results. You might be surprised at just how many factors they consider before even one bracket is placed or an incision is made.
So if you've ever wondered what truly goes into transforming a smile and correcting, significant jaw discrepancies, or if you just love a peek into the precision of complex medical fields, you're definitely in for a treat. Okay, let's dig in. First off, let's talk about why. Why this combination of braces and surgery? Our sources really emphasize that for moderate to severe bite problems and facial deformities in adolescents and adults, you pretty much need both working together to get the best outcome.
Exactly. It's not usually an either situation in these cases. The core goals are always centered on you, the patient, addressing your specific concerns, establishing optimal chewing function, and achieving excellent aesthetic results. But the roles of the two specialists are quite distinct.
Right. So the orthodontist, they're like the master architect for the teeth themselves, moving individual teeth, maybe the bone right around them, the alveolar bone.
That's a good way to put it. They handle the tooth alignment within the bone. But what they can't really do is shift the underlying jaw structure itself. That's the limit.
And that's where the surgeon steps in.
Precisely. The oral and maxillofacial surgeon, or OMF surgeon, they're responsible for surgically repositioning the entire jaw, or sometimes both jaws, and the associated structures. It's a true collaboration. The orthodontist sets the teeth up perfectly so they fit when the surgeon moves the jaws.
And even before that starts, the sources highlight this absolute importance of, well, empathetic listening and a really comprehensive analysis. It's not just looking in your mouth.
Not at all. It goes way beyond simple photos or dental models. We're talking advanced imaging like CT scans, cephalograms, getting a complete picture of your facial structure, your skeleton.
Cephalograms, those are the profile x-rays, right?
Yes, precisely. They give detailed measurements of skeletal relationships. And while our deep dive today focuses mainly on the orthodontic side, it's vital to remember that the whole picture includes patient concerns, psychosocial factors, how well you chew, any airway issues, speech, even TMJ problems, issues with the jaw joints.
TMJ, right.
The orthodontist takes all of this information, synthesizes it, and determines specific personalized goals. That leads to a truly tailored plan, not some cookie-cutter approach.
Okay, here's where it gets really interesting for me, the sheer depth of the diagnostic process. Our sources list out, I think it was 13 key evaluations an orthodontist makes. It's way beyond just straight teeth.
It really is. It's about the entire dental architecture, the bone underneath, how everything works together. It's incredibly thorough. Think of it like a detective gathering all the clues before solving the case.
So what are some of those key evaluations?
Well, we can group them. First, let's look at the sort of structural foundations. Arch length, for instance. That measures the total width of your teeth against the actual space available in your jawbone.
Okay, so do the teeth fit in the jaw?
Pretty much. It helps the orthodontist figure out if there's crowding or maybe too much spacing. It gives the first hint about whether teeth need significant movement, or, in some cases, if extractions might even be needed to create space.
And that relates to the arch width analysis too, right? Looking side to side.
Exactly. Evaluating the transverse width, how wide your arches are. This is crucial for how the upper and lower teeth will eventually mesh together after surgery. For example, someone with a class 2 bite, where the upper jaw might seem too far forward if you simulate the ideal bite position on models, the upper jaw often looks too narrow.
Ah, so it tells them they might need to expand the upper jaw.
Precisely. It shows a discrepancy that needs addressing. Then there's incisor inclination. That's about how much your front teeth are tilted relative to the jawbone itself.
Not just how straight they look, but their angle.
Right. The goal is to get those incisors positioned correctly over the underlying basal bone. This often means moving teeth away from what we call compensations, positions they might have naturally drifted into to sort of mask the real jaw problem. They're aiming for very specific angles.
Okay, so that's the overall structure. What about individual teeth?
Good question. Tooth size analysis is fascinating. It literally compares the widths of your upper teeth versus your lower teeth. Did you know the source says about 40% of patients needing this kind of surgery have a tooth size discrepancy, or TSD?
40%, that seems high.
It is significant. Often it's the lower front teeth being a bit too large compared to the uppers, maybe because the upper lateral incisors are naturally small or peg-shaped.
And why does that matter so much?
Because even if the teeth are perfectly aligned, if their fundamental proportions are off, you won't get a stable interlocking bite. It just won't fit right. Orthodontists use something called Bolton's analysis to measure this precisely.
Bolton's analysis, got it. So if there's a discrepancy, a TSD...
Then they have to plan for it. Maybe reshaping the teeth slightly later, or planning to build up smaller teeth. It's thinking ahead.
What else? You mentioned the curve of Spee.
Ah, yes, the curve of Spee. Imagine looking at your teeth from the side. It's the curve formed by the chewing surfaces from front to back. Normally, it's a gentle curve.
Okay.
But if it's exaggerated, too deep, it often means a deep bite where your top front teeth cover too much of the bottom ones. If it's flat or reversed, that can indicate an open bite where the front teeth don't meet at all. It's fundamental to how your bite functions.
Makes sense. Now, you also mentioned looking for existing problems.
Absolutely critical. Obvious things like dental problems, missing teeth, big cavities, failing restorations, they clearly impact the plan. But then there's something potentially trickier. Tooth ankylosis.
Ankylosis. Fused to the bone.
Exactly. The tooth root fuses directly to the jawbone, bypassing the normal ligament.
Yeah.
And that means it will not move with braces.
Whoa, how do they even spot that? It sounds hidden.
The best test is surprisingly low-tech. Percussion, tapping the tooth. An ankylosed tooth makes this distinct, high-pitched, clear, almost metallic sound.
Really? Just by tapping?
Yep. A normal tooth has a duller thud because it's cushioned by that ligament. If you miss an ankylosed tooth, it can wreck the whole treatment plan because it acts like an unmovable anchor. Major problems can result.
Wow. Okay, that's a crucial detail. And gum health too, right? Periodontal status.
Definitely. Pre-existing gum disease or areas with very thin gum tissue, especially around the lower front teeth, that needs to be addressed before orthodontics start. You can't move teeth effectively or safely if the supporting gums and bone aren't healthy.
Like building on a solid foundation.
Precisely. And our sources also get into tongue assessment, specifically looking for macroglossia, an enlarged tongue.
An enlarged tongue. How common is that?
True macroglossia isn't super common, but can be a factor. It's not just a quirky feature. A truly large tongue can actually contribute to pushing teeth out of alignment, causing open bites or making the lower jaw grow forward more. It can even cause instability after treatment.
So the tongue can literally undo the work.
In cases of true macroglossia, yes, it's a risk factor for relapse. They look for signs like a very large, wide, flat tongue, maybe scalloping on the edges where it presses against the teeth. But it's important to distinguish this from pseudomacroglossia.
Pseudo, meaning false.
Right, where the tongue looks big only because the jaws themselves are small or set back. In most open bite cases, the tongue isn't the primary cause. It's actually quite adaptable. But if true macroglossia is diagnosed, the treatment plan has to account for it.
Fascinating. And the last one was TMJ assessment, the jaw joints.
Yes. TMJ problems often go hand in hand with jaw deformities. Ignoring existing joint issues like clicking, pain, or arthritis is a major reason for complications after surgery. So sometimes TMJ issues need to be treated first, potentially even with TMJ surgery, either before or during the orthognathic surgery itself.
So it's a truly holistic view. Okay, they've done all these diagnostics, made a problem list. What are the specific orthodontic goals before the surgeon steps in? What's the aim?
The basic goals are, well, first, align the teeth properly over the underlying jawbone, avoid excessive vertical movements that might be unstable, and crucially, they need to decompensate the teeth.
Decompensate, what does that mean?
It means moving the teeth out of positions where they might have naturally shifted to hide or compensate for the underlying jaw mismatch. You actually want to make the bite look worse orthodontically to fully reveal the skeletal problem that the surgeon will fix.
Okay. So you're setting the stage perfectly for the surgical correction.
Exactly. You're positioning the teeth ideally relative to their own jawbone, so they'll fit perfectly once the jaws are moved. They also aim for stable, predictable movements,
Yeah.
and
Okay.
sometimes avoid certain orthodontic movements altogether if they're better handled surgically.
And the source mentioned really specific angles for the incisors, didn't it? Like down to the degree?
Oh, yes. Incredible precision. Aiming for, say, the upper central incisors to be at 22 degrees plus or minus 2 degrees relative to a specific reference line on that cephalogram X-ray. It shows the level of detail.
Which leads to that blueprint you mentioned, the STO.
Right, the surgical treatment objective, or STO. It's essentially a prediction tracing, often done manually on acetate paper over the cephalogram or using software. It shows how the bones, teeth, and even the soft tissue profile are expected to change with the planned surgery.
So everyone's on the same page about the final goal.
Exactly. There's usually an initial STO done early on to set the overall goals, and then a final, very precise STO done right before surgery to finalize the exact surgical movements.
Before braces even go on, though, basic dental health needs to be sorted.
Absolutely non-negotiable. Any cleanings, fillings, gum treatments like scaling or grafting that has to happen first. Maximize the health of everything before starting major work.
And during the pre-surgical braces phase, anything special?
Accurate bracket placement is paramount, obviously. And the type of arch wire used is important. They might use flexible nickel titanium wires initially for alignment, but sometimes, especially with things like open bites, they might switch to stiffer stainless steel wires with specific bends, or use sectional wires to apply very controlled forces and avoid unwanted side effects.
And the source had a warning about certain elastics before surgery, Class 2 mechanics.
Yes, that's a really important point. Long-term use of things like Class 2 elastics, which are often used to correct overbites, or certain functional appliances used for growth modification, if used extensively right before surgery, can actually cause the tissues in the TMJ, the jaw joint, to thicken.
Thicken.
It's like the joint adapts to that forward posturing. But then after the lower jaw is surgically advanced, those thickened tissues can slowly remodel or thin out again, and that can lead to bite changes or relapse.
So they might actually use opposite elastics briefly.
Sometimes, yes. Very light Class 3 mechanics might be used for a short period right before surgery to try and counteract or reverse that thickening effect in the joint. It's quite nuanced.
Okay, so let's talk about tackling some of those specific... What are the orthodontic options before surgery?
Right, for TSDs. If the issue is the lower front teeth being too wide compared to the uppers, one common technique is interproximal tooth size reduction, or IPR.
That's the gentle reshaping between teeth.
Exactly. Using fine diamond strips or discs to remove a tiny amount of enamel between the contact points. The source mentions up to 3 millimeters total can often be safely removed from across the lower front 6 teeth without harming them.
That sounds incredibly precise. What if the problem is small upper teeth, like those lateral incisors?
Then the approach is different. They might use orthodontics, like coil springs on the arch wire, to intentionally create arch space around those small laterals.
Gaps.
Yes. And then, after all the orthodontics and surgery are done, those small teeth can be built up to the correct size and shape using dental bonding or veneers to fill the planned spaces.
Ah, so you plan the space for the final restoration.
Precisely. In really large TSD cases, though less common, extracting a single lower incisor might be considered, but that has knock-on effects for the bite and arch symmetry that need careful management.
What about just general crowding or teeth that are tilted too far forward?
Several options there. Sometimes extracting bicuspids premolars further back allows space to retract the front teeth. Other times expansion might work. In really severe cases, sometimes segmental surgery is planned, where the surgeon cuts the jawbone between teeth to move segments. But expansion needs care. Pushing teeth outwards too much can tip them buccally, affecting the bite negatively.
And if bone cuts between teeth are planned surgically, the orthodontist has a special job first.
Yes, a crucial one. If an interdental osteotomy is planned, the orthodontist must use the braces to purposefully tip the roots of the teeth away from where the surgeon is going to cut.
Tip the roots apart. Why?
To create enough bony space for the cut and, more importantly, to avoid damaging the tooth roots during surgery. It also helps prevent gum problems like black triangles between the teeth afterwards. It requires very specific bracket positioning to achieve that root divergence.
That's amazing foresight. What about the opposite problem, teeth tilted inwards, like in some Class 2 cases?
Correcting decreased inclination, often seen in Class 2 Division 2 cases where the front teeth are tipped back, might involve just aligning things, maybe opening up space slightly to allow them to upright.
And that curve of spee, if it's too deep?
Especially in the lower jaw, an excessive curvicity often goes with a deep bite. Orthodontically, they can try to intrude the lower front teeth, push them down slightly. But the source suggests this can be prone to relapse. Often, surgical leveling via osteotomies provides a more stable, long-term result for significant curves.
So sometimes surgery is just the better option for stability. The extraction versus non-extraction decision sounds complex too.
It is. It weighs up everything.
Yeah.
Incisor position, how much crowding there is, any TSDs, the curve of Spee, asymmetries in the arch. Sometimes expanding the arches is viable instead of extracting, but again, you have to watch out for instability and excessive tipping of the back teeth.
And if someone's missing teeth already?
The trend now is usually to open or maintain space for a future dental implant or bridge. Using orthodontics to close large spaces, like substituting a canine for a missing lateral incisor, is done less often now because the aesthetics and function usually aren't as ideal as an implant.
What about those ankylosed teeth, the fused ones? Can anything be done?
It really depends. If it's a baby tooth, it's usually extracted. If it's a permanent tooth, especially in an adult, it's tricky. Sometimes, if diagnosed early, a procedure called surgical luxation, where the surgeon carefully breaks the fusion followed by immediate orthodontic force, can get the tooth moving again. But it's not always successful. Other options might involve segmental surgery around the tooth, or even extracting it and planning for an implant.
Okay, we've covered a lot of the pre-surgical planning and challenges. Let's fast forward. What happens right before surgery and immediately after?
Right. So for the final pre-surgical preparation, new records, like models and x-rays, are usually taken to confirm everything's ready. The orthodontist makes sure the braces have suitable hooks or attachments.
Hooks for what?
For the surgeon to use during or right after surgery. They might need to wire the jaws together temporarily, or more commonly, attach guiding elastics. The source strongly prefers ball hooks that are built onto the brackets themselves, rather than hooks crimped onto the arch wire.
Why the preference?
Because hooks on the arch wire can slide, or the wire itself can flex, leading to unwanted tooth movements when elastics are applied post-surgically. Hooks on the brackets are more stable. And the final wire placed before surgery is typically a heavy, rectangular stainless steel wire.
Heavy and stiff to hold everything steady.
Exactly. To provide maximum stability and control for the surgeon and the immediate post-op period.
And after surgery, you mentioned surgical splints?
Yes, often a stabilizing splint is used, especially after upper jaw surgery or complex movements. It's a custom-made acrylic device, usually wired or bonded to the upper teeth. Our sources really recommend a specific type, a palatal splint.
Palatal, meaning on the roof of the mouth.
Yes, it's horseshoe-shaped and sits against the palate, but crucially, it doesn't cover the chewing surfaces of the teeth.
Why is that important?
Several reasons. It provides excellent stability, especially side to side. Because it doesn't cover the teeth, the orthodontist can actually see the bite immediately after surgery to check the fit. It also allows for easier cleaning and even allows some minor orthodontic adjustments to start sooner if needed.
What about other types of splints?
The more common occlusal coverage splints, the ones that cover the chewing surfaces like a night guard, are used, but the source points out drawbacks. They can hide the actual bite, making it hard to assess. They can make post-surgical orthodontics more difficult, interfere with hygiene, and potentially lead to tooth discoloration or decay underneath if worn long-term. Mandibular splints, similar in concept to palatal ones, can be used for the lower jaw.
How long do these splints stay in?
Typically around 1 month, maybe a bit longer, for very large maxillary expansions where more healing time is needed for stability.
And then comes the post-surgical follow-up.
Yes, often weekly visits initially. The orthodontist checks the bite meticulously, monitors healing, and adjusts guiding elastics as needed.
And you mentioned checking the bite in a specific position.
Right. Critically important, especially if TMJ surgery was also done. The patient should be sitting upright or maybe slightly reclined, not lying flat. Lying flat can cause the jaw joints, the condyles, to seat inaccurately, giving a false impression of the bite. You want them seated naturally.
What if the bite isn't quite perfect right after the splint comes out?
This is where aggressive post-surgical orthodontics comes in, aggressive meaning proactive and timely. The good news is teeth tend to move much faster right after surgery.
Faster? Why?
Because of the increased bone metabolism associated with healing. It's called the regional acceleratory phenomenon, or RAP. Bone turnover is higher, so teeth respond more quickly to orthodontic forces. What might take 4 to 6 weeks before surgery could take just 1-2 weeks after. So light elastics are usually very effective for detailing the bite.
But there are warnings, too, about specific elastics.
Yes. Vertical elastics, used to pull upper and lower teeth together, need close monitoring. While they provide support, prolonged heavy use, especially in people who breathe through their mouths or talk a lot, can actually pull the front teeth out of their sockets, slightly extrude them. This can lead to the back teeth not meeting, a posterior open bite.
Okay, so careful with those. And the source had a strong warning about power
A
chains.
very strong warning, specifically about using power chains across the upper front teeth post-surgically. Power chains tend to apply a torque force that can tip the crowns of the incisors backward while flaring the roots forward.
And that causes problems.
Yes, it can lead to those upper incisors hitting the lower ones prematurely when biting, which then props the jaw open slightly and prevents the back teeth from closing fully again, causing a posterior open bite. It's a common cause of post-surgical bite issues if not avoided.
Wow. And what about those spaces they might have created earlier for the small teeth?
Ah, yes. If spaces were opened pre-surgically to correct a TSD, like for small upper laterals, it is absolutely critical that those spaces are maintained post-surgically. They must not be closed with orthodontics,
Why not?
because closing them defeats the whole purpose. It reintroduces the tooth size discrepancy, which can lead to major bite problems, posterior open bites again, increased stress on the TMJs, potentially relapse, and even pain. Those spaces are planned for the final restorations, bonding, or crowns.
So maintain the plan. Okay, after all this detailing, how long does post-surgical orthodontics usually take?
Typically a minimum of 4 to 6 months, sometimes longer depending on the complexity. Once the bite is settled and stable, then it's time for retainers.
And the source had specific recommendations for retainers too.
Yes, they strongly recommend rigid retainers that do not cover the occlusal chewing surfaces, things like traditional Hawley retainers or wraparound retainers.
Why not the clear plastic overlay retainers that cover everything?
Because retainers that cover the chewing surfaces don't allow the teeth to naturally settle into their final bite position. They can actually hold the bite slightly open, potentially causing or perpetuating an open bite malocclusion. They also don't provide as good transverse side-to-side stability as a well-made Hawley retainer with a rigid palate or lingual aspect.
So even the retainer choice is crucial for long-term stability.
Absolutely. This whole detailed process underscores that relapse is a real possibility if any step isn't managed correctly. Things like transverse instability from overexpansion, closing those TSD spaces inappropriately, or not addressing underlying TMJ issues can all lead back to problems. The goal is stable orthodontics, precise surgery, and meticulous, appropriate retention.
Wow. That was truly a deep dive into an incredibly precise and complex field. You can really see that correcting these dentofacial deformities, it's so much more than just straightening teeth. It's this meticulously planned interdisciplinary journey.
It really is. It highlights the profound interconnectedness of, your teeth, your jaws, your joints, even your airway and tongue, and how seemingly small details, the angle of one tooth, the exact size difference between upper and lower teeth, play such a critical role in the overall outcome and the long-term stability.
It's like watching a master architect and a master engineer working together on the same intricate project.
That's a great analogy. And the emphasis throughout the source material on understanding patient concerns first, combined with the extreme precision needed at every single step, it really makes you appreciate the artistry and the science involved. From knowing average tooth widths down to the millimeter to understanding exactly why one type of elastic might cause problems post-surgery, it's all connected.
It's about building a smile that isn't just beautiful, but one that's perfectly stable and functional, hopefully for a lifetime.
Exactly. And this leads to, well, an interesting thought perhaps for you to ponder. We talked about the tongue's adaptability, how it often adjusts to new jaw positions. Considering this incredible adaptability within our own bodies, how much more could we potentially learn by looking closely at other adaptive biological systems within us? What unexpected roles might they play in our overall health, perhaps in ways we don't even suspect yet?
That is something to think about. What stood out to you from today's deep dive? Send us your thoughts. Thank you for joining us on this really enlightening exploration. We'll catch you on the next deep dive.